good evening, Vanakkam, to everybody who's here. We'd like to start off with a big thanks to Asian College of Journalism for hosting this event with us. They've really been amazing. The principal, Mr. Sashikumar, is unfortunately not able to make it today, but we just want to thank him for readily accepting for this. And of course, with a speaker like Dr. Rajagopal, it's too tempting and nobody will say no. So thank you and welcome to the second Keshav Desiraju annual lecture. This is dedicated to someone I think who most of you know. For those who don't know him, he was a bureaucrat par excellence, a true patriot, an artist, a scientist, and the architect of the National Mental Health Policy and the Mental Health Care Act of 2017. He was also a board member at the Banyan Academy. He was a board member of Pallium and Cognizant Foundation. Cognizant Foundation, after he passed away 2 years ago, and they said, we have to do something. We just have to do something in his memory because his contributions are vast, deep, and they will benefit generations to come. So this is the least, as citizens of the country and as the part of the Banyan family, as part of the Cognizant family, this is the least we could do for him. And there's a lot more coming by way of museum, library, talk circles, and he deserves this and so much more. I will hand over the mic to Dr. Lakshmi Shankaran, one of the directors at the Banyan Academy, to introduce Mr. Narayanan from Cognizant Foundation, and then we will proceed with the lecture. Thanks once again and good evening.
Hi everyone. It gives me great pleasure to introduce all of you to Mr. Narayanan, who is a director of Cognitive Foundation, the General Council India and APAC. We're really grateful for all the wonderful support, and he is a senior vice president for the organization, and he has over 30 years of diverse experience that includes independent private practice, in-house counsel for banking and manufacturing sectors. He is experienced in mapping and managing legal reputation and regulatory risks, at the same time effective planning and budgeting. His experience spans all aspects of legal expertise, and he heads the in-house India team and the APAC team of 70 legal professionals. Under his leadership, the legal team has won the coveted award of IT in-house legal team in the year 2021 and 2022, presented by the Legal Era Media Group. So we're really honored to have you, sir, and we're really grateful for the wonderful support that Cognizant has been extending to the Banyan, I must say, to the OP services in providing medication to all our clients across the Tamil Nadu state. Thank you so much.
Thank you, Dr. Lakshmi. I'll request Mr. Narayanan to please say a few words.
So good evening, everyone. Dr. Rajagopal, Chairman Emeritus of Pallium India. Dr. Saumya Swaminathan, former Chief Scientist, WHO. Psychiatric doctors, medical professionals, government officers and print media, the Banyan, CSR Foundation, Banyan beneficiaries and social work students. I'm glad to be here today. Keshav Desiraju is one of our Cognizant Foundation board member, and his contribution to Cognizant Foundation is something unique. We cannot forget him, for all that what he has done. And I'm so honored to be here to participate in the second edition of Desiraju Memorial Lecture. And I like the word celebrating the life of Keshav Desiraju. Obviously, this is one life we need to celebrate. So before I don't want to spend much time here. I know we are all eagerly waiting for Dr. Rajagopal to speak. So let me be very quick and fast. So as you all know, there is no health without mental health. But the first and foremost thing, according to me, is acknowledging that there is a problem and accepting it and move forward with it. It's also important that we commit to create a culture where mental health is valued, where people feel safe to speak openly about their struggles, and where everyone is empowered to take care of the mental well-being. The mental health of underprivileged women is essential considering their vulnerability to mental health issues while struggling to make their ends meet. Some of them may have to face domestic violence and abuse, and some of them cannot take care of their family, and some of them are driven away from their houses. On that note, on behalf of Cognizant Foundation, I would like to thank and appreciate Mrs. Vandana Gopikumar and the entire Banyan team to have successfully demonstrated that one can develop treatment care and rehabilitation strategies for mentally ill homeless women using the comprehensive community approach both in rural and urban areas. Can we give a good big round of applause, please? Thank you. It's heartening to note that Banyan's model has widely been replicated and has laid foundations for building a cadre of non-specialized mental health programs and workforce to transform the standards of treatment rehabilitation of mentally ill persons in India. Now, coming to Cognizant Foundation. So, Cognizant Foundation is one of the channels of Cognizant corporate social responsibility initiatives in India. So, we have two different arms. One is the Cognizant Outreach Arm, which is part and parcel of Cognizant, and another is a separate entity because we wanted to make sure that our foundation is independent and can do things independently, where we have independent board directors, and that is Cognizant Foundation. So when it comes to Cognizant Foundation, basically what we do is we build a sustainable ecosystem at the intersection of inclusion, technology, and collaboration. The foundation's initiatives are along with two thematic areas. One is health for all, and the next one is future for all. So, well, health for all basically takes care of program support for all, enables persons with disabilities and children with special needs, ranging from addressing barriers to mental health to early intervention and rehabilitation services. In this regard, we connected with Banyan in 2016, and we started working with them very closely. Since June 2023, Cognizant Foundation is supporting close to 1,250 patients and few caregivers of patients through Banyan's outpatient clinics and after-care services in Chennai, Tiruvallur, and Chengalpattu districts of Tamil Nadu with pharmacotherapy support. Once again, it's a great privilege to partner with Banyan for this memorial lecture series. As I said earlier, Mr. Keshav Desiraju means a lot to us for Cognizant. We strongly, wanted to follow the footpath of Mr. Keshav Desiraju and in strongly advocating the need for promoting mental health program. We all are eagerly looking forward to listening to Dr. Mr. M.R. Rajagopal, Chairman Emeritus of Pallium India, and I wish the lecture series on the Banyan a huge success as it will help to promote the need for palliative care and mental health. Thank you.
It's rather poignant that we're in an auditorium which is called the MS Subbalakshmi Auditorium. I must mention this. And Dr. Keshav Desiraju wrote a wonderful book, tracing her story. So Mrinalini just mentioned it and I said, wow, that's so beautiful. And I'm sure he's watching all of us here today. Anyway, without much ado, I have the pleasure of introducing all of you to Dr. Saumya Swaminathan. I think all of you have heard a lot about her, and we're really privileged to have you as our chief guest today. Thank you so much for coming. And she was formerly the WHO's chief scientist, and before that, the Director General for Programs, and a lot of focus on research, quality assurance of norms, standards of digital health. And we're all aware of her role that she played during COVID times, and importantly, setting up equitable vaccine distribution to the LAMIC countries. That's really awesome, and we've all been privileged to be vaccinated along with the rest of the world. And she's also been, of course, globally recognized and continues as a researcher on tuberculosis and HIV with 3 decades of clinical experience and care, and throughout her career to translate research into impactful programs on the ground. That's the most important thing to sort of, introduce her in that context. And she brings a lot of evidence into health, policy making, building research capacity in Indian medical schools, and forging South-South partnerships in health sciences. She has also served as a coordinator of the UNICEF, UNDP, World Bank, WHO Special Program for Research and Training in Tropical Diseases. She has published more than 450 peer-reviewed publications and book chapters, and so on. It's an extensive, wonderful biograph, and we're really grateful to have you, Dr. Saumya. Thank you for joining us today. Thank you so much, and a few words from you. Thank you.
Thank you so much for that very kind but I think unnecessarily long introduction. I would have come anyway to listen to Dr. Rajagopal, so very happy and that Vandana reached out and told me about this event. We've all come here to listen to Dr. Rajagopal, so I'll just say a few words. I have known him now for some time. When I was Director General of the ICMR, we had met at a program it was something to do with ethics and ethical guidelines. And then he, during a brief coffee break or something like that, you know, he, in a very short period of time, but very succinctly told me about the issue of the end of life and the definitions that need to be clarified as to, you know, the different modes of dying, what is end of life, and the legal need for that kind of definition. Supreme Court was actually looking into that matter, and there was a lot of confusion in the air. So that actually got me thinking about this, something which probably had not struck me, because you do so many different things as head of the medical research organization. But we did get working on that, set up a committee, and which made very good recommendations to the Supreme Court. So Dr. Rajagopal is a pioneer in his area, and I think if you have not read his book, Walk with the Weary, it really is a book that really touches you and moves you, and it's very clear that from a very early young age, he had that quality of empathy and compassion, which of course ideally every medical professional should have, but some have much more, I think, than others. It just comes very naturally that when you see pain and suffering, you want to do something about it, and also not taking no, I think, for an answer, because it's quite difficult to do something new and set up a new field, a new area of work. You meet a lot of obstacles. Half the people, because of ignorance, you know, say that this is not important. The other half, you know, somewhere it gets entangled in a lot of bureaucratic things. So palliative care, I think people who suffer or who've seen relatives suffer, not just with cancer, but with many other illnesses that cause prolonged disability or suffering, will very much relate to the need to provide some kind of recourse, particularly when it's severe pain. But even if it's not pain, it could be other kinds of suffering. And the whole family, of course, suffers. And I've worked in TB for a long time, so I've seen that kind of suffering. So it doesn't have to be cancer, it can be many different kinds of diseases. So he asked me to be on the board of Pallium India, so I'm very privileged because it does such wonderful work. I've had the opportunity to go out with their teams into the community around Trivandrum and see the kind of work that they do in the community there. I wish that all places in India had, you know, this kind of wonderful palliative care program, which of course is very much community based and community owned, which is, I think, what makes it so successful and so special. But you can see the difference it makes to those families. Like I said, even when the patient is not necessarily in pain, they have so much going on in their lives that need that kind of psychosocial support. So I think as a doctor, we're often not given much training or exposure on those aspects of life, the more what we would call maybe the social determinants of health, the more psychosocial aspects of well-being, which are just as important as physical health. And so medical doctors tend to look at physical health, do what you can, and then the rest is not within our mandate. So I think that whole concept of wellness and well-being really needs to change. And even if we can't do everything, we at least need to become advocates for addressing these other determinants of health, which I think in today's age they are becoming even more important than they were. And so access to a doctor or a health facility is only one small, very small aspect of how healthy a life you're living. In fact, it is all the other things around you that determine whether you're healthy or not. And so this is why I think this whole approach, while he's, talks about palliative care, but it has lessons well beyond that to how we approach health and well-being. Of course, if I start reading his biography, it will go into many hours I'll have to spend. But he's made some very fundamental, issues that he brings to the table as part of WHO committees, as part of the Lancet Commission, most recently on the value of dying, and contrasting the way that people die in different societies, and really trying to see like what sort of value do you put on it, what kind of death does one, because everybody has to die, but what kind of death do you want to have, and how can you actually do something about it? How do you make the conditions right? So I think these are very fundamental questions, can't really be, and they're also philosophical, they are spiritual, they go beyond the realm of what you can read from a textbook. And so with those words, I am again happy to be with all of you, really looking forward, Dr. Rajagopal, to your words today. Thank you.
Good evening, everybody. Namaste. Dr. Saumya, thank you very much for the kind words, and team here, Dr. Kishore, Dr. Vandana, everybody, thank you very much for this opportunity. In 12 years back, the World Health Assembly was meeting in Geneva, and at that time, my organization, Pallium India, was working with Human Rights Watch, the international organization, on global access to pain relief. We were organizing a side event. Side events are usually held at lunch break, where we serve lunch and get people to come and listen. I heard a lot about Mr. Desiraju, about his pragmatism and integrity. I wanted him to come to the meeting. I didn't know him. I went around looking for everybody with an Indian face, and on the 5th attempt, found him during tea break in the cafeteria. I went and told him, like, I'm so and so, we are working on this access to pain relief and palliative care. We are holding a side event. It will be very important for India that if you will come and attend this. He looked up and said 3 words, I will come. That's it. Done. He came, sat through the whole 1 hour of deliberations by including several representatives from countries, including a minister from Uganda. And as soon as the session was over, he had left the room. Within a week, I got a call from Delhi saying that a committee has been formed to discuss a national program for palliative care. And in 5 months, India had its national program for palliative care. The program would have been something else today if he had continued in that chair for some time, but he had to move, and that's a very, very sad story which does not tell much in praise of the integrity of our lawmakers and managers. That kind of pragmatism I have seen only in you, Dr. Saumya. The way you got, and she didn't know me. I went and said, I had about a minute, and I said, this is a need. I can't see the Medical Council of India doing it. Can ICMR do it? And again, in a few months, all the action happened, and we had that precious document, which is still very valuable to us. So I am very grateful to that man, Keshav Desiraju, and to Dr. Saumya, and to so many people here who are working on human health. This morning, the current chairman of my organization, Mr. Binod Hariharan, and I left. And I spent the morning in the Banyan. And I can tell you, it was a true experience. My God, experience of a lifetime. One of the things was the way everyone's eyes were lighting up. We were sitting and talking, and they were explaining the whole mission and what they do. And as we were talking, the door was burst open, and a painfully thin woman wandered in, one of the patients. And some of the caretakers came behind her to take her away. But Vandana said, no, let her in. She came and took part in the meeting, quietly sitting there, drinking tea and coffee alternatively, grabbing everybody's cup and having it. But I was amazed at the way in which the team treated her. If you ask, who is the most important person on the premises in your institution, Dr. Vijayalakshmi or Dr. Matthew, who would be the most important? The person. We say that often, but they made that happen. So I was reminded of these words from Tagore in the Gitanjali. Leave this chanting and singing and telling of beads. Whom dost thou worship in this lonely dark corner of a temple with doors all shut? Open thine eyes and see. Thy God is not before thee. He is there where the tiller is tilling the hard ground and where the pathmaker is breaking stones. I don't have to go to any temple. If I want to see God, I can just come to Banyan. God is present there. With all respect to my host, so many people in whom there is a lot of God. There's a lot in you also, Dr. Daras. Many people that I don't know. Thank you for this privilege, and I want to talk to you about always about palliative care, but also particularly about mental health and palliative care. Remembering him with great gratitude and moving forward. When you want to take a long journey, you take an aircraft or a train most of the time, and both are efficient. The problem is, it will take us to a particular station. Even if you want to go to a town 17 kilometers away, it will take you only to the station or to the airport. And unfortunately, very often, all the action is concentrated on that target. And that is true for healthcare also. Healthcare now concentrates on the institutions that we create. That's where the train takes us. The person who needs the care will not be anywhere there. This is how health is officially defined by the World Health Organization. The definition is almost as old as myself and still stands. Physical, social and mental well-being, and not merely the absence of disease or infirmity. Everybody here is connected with healthcare in some way or other. Is that what we really give? Is that what I and Dr. Saumya were taught in medical college, or a generation later Dr. Daras is taught in medical college, or still another generation later the medical student is being taught today? We were taught about the body, about the organs, about microbes and tumors, about chemistry. Nobody taught us to look at a person. A rather famous Australian by name Eric Castle said, it is not bodies that suffer, it is persons. And what we need to do is to look at the physical, social and mental well-being and not at diseases alone. Of course the diseases are important, but it is pointless if we overcome the tumor and keep the person destroyed in mind, spirit, and if his family is wiped out by catastrophic health expenditure. Can we just switch off this light on the front? Is that possible? Oh, that's a lot better, isn't it? Thank you. In India, despite Sri Keshav Desiraju's National Program for Palliative Care, even now, less than 4% of the needy. Actually, it should be even much less, I seriously suspect, because it's a generous estimate. At least 96% of people do not have access to basic pain relief. Everybody here who has gone through a really severe pain experience would know how bad it is. Maybe if it was a short experience, like a toothache, or something more severe like labor pains, then it is time bound and time limited. But imagine somebody like that. This man had a curable cancer, but he went to the hospital, and at that time, many years back, because it was a government hospital, it was not a huge expense, but they wanted 25,000 rupees to be paid at that time. Now more free treatment is available. He did not have it. He went back to work and went on working till the tumor became incurable. Now he went back to the hospital. He couldn't swallow anything. They gave him a nice scolding for not getting treated at that time. Said, we can't do anything more. Put in a tube to feed him because he would get obstructed, and send him back home. He said what he felt was like somebody putting a nail into his ear and striking it with a hammer. And the hammering would go on for 10 minutes, then stop for some time. Then it would start again. I can't imagine that happening to me once. Unimaginable. But that is the way pain can be in many diseases, including peripheral vascular diseases, cancer, and many neurological problems. Unfortunately, most of that can be treated with very inexpensive medicines. That's the problem. It's too inexpensive to take care of that pain. Who is interested in inexpensive modalities of treatment? Well, I talked about pain and other symptoms, breathlessness, fungating wounds, many things. But they are only the tip of the iceberg. If you remember, go back to those middle school lessons, painful lessons at that time, you would remember that only 1/10 of an iceberg is visible on the surface. 9/10 is hidden. What you see is the pain, the vomiting, the difficulty in swallowing. And so long as that is there, the rest is not visible. It's very difficult to identify underlying emotional suffering or social suffering at that time. But when we take care of the main symptom, which may be overpowering, we come across a lot of problems hidden below. Michael Kearney calls it the symptom management surface work and everything else the depth work. The fear that he has, the guilt that he carries when his children go hungry because the expense of his travel to the hospital, the guilt about not getting the treatment at the right time, the depression, the anxiety, all of that is making his life miserable. And the social issues. Everybody here who gets an occasional headache or a toothache would know that you are irritable at that time. When you have that migraine that comes on, life is difficult for your children. You snap at them all the time. You snap at your spouse. When you are angry, the other person also gets angry. And in anger, especially in conditions like this, some words are spoken which cannot be taken back. And there's a rift between spouses, between parents and children, and between other relatives. And social issues are not only there. In our country, financial issues are of greater dimensions than you would guess. In 1 year, in our country, India, how many people would be going below poverty line by catastrophic health expenditure? You want to take a guess? Thousands? Tens of thousands? Lakhs? Millions? Crores? It is 5.5 crores. This was 2015 estimate by a group of Indian doctors published in the British Medical Journal. 55 million Indians are pushed below poverty line by catastrophic health expenditure in 1 year. More than 4% of the population. What happens to their families? What happens to the next generation? What happens to their schooling? India, by World Bank data, India is one of 12 worst countries where catastrophic health expenditure happens to this magnitude. One of the 12 worst. And some questions need to be asked. We said health is physical, social and mental well-being. What? That's a joke. That's a joke if we are treating disease and destroying more than 4% of the population just 1 year, destroying their health and the next generation also. And spiritual, that person's feeling, why am I alive? Why did God do this to me? Is there a God? There is no God. What's the purpose of my being there? I wish I had the strength to kill myself. And something more at the greatest depth, sexuality issues, never talked about. I don't necessarily mean issues related to a sexual intercourse. It's about a man feeling a man and a woman feeling a woman. And being attractive to the other person, leave alone being attractive, with a nasty ulcer here, the person feels, she wouldn't even want to see me like this. Maybe she is just hiding her hatred for my appearance. And a distance starts mounting. And very often, the people find it easier to talk about it than we medical people. We are particularly bad at asking those questions which will draw out problems, so we run away. We turn the other way and just ignore that some things do not exist. Ladies and gentlemen, all these things are in the depth work that we can do and we need to do. And when we do all this, along with treatment of disease, this becomes palliative care. So, that railroad is to go to not at only at this station, all those areas, not only physical suffering, the social, spiritual and emotional domains, social including financial, all this needs to be addressed. Is that possible? Can we solve the problem for those financial issues? My God, at least we can give rational prescriptions. Before writing that medicine, we can ask ourselves, is this really necessary? Is pregabalin really the best? Shouldn't we rather be using the inexpensive amitriptyline for that neuropathic pain? Do we ever give a thought to cost of medicines or cost of procedures? When we do advise a scan, CT scan, to assess whether the tumor has gone into the cranium, what's the point? Is that going to make a huge difference to the treatment? Just for our clinical curiosity, why should you find that out at the cost of the children's food? So these are some issues that we'll have to ask, and all these can be done. And when I say, some people will say, well, can all that be really done? But I will say yes. Then the next question is, oh, it is not easy. And my response is, why does it have to be easy? All the easy things have been done by somebody else. Only the difficult things are left behind. And if you address them, even if you cannot remove all the problems, even addressing some of them makes such enormous difference to that person and the family. One story. A woman about 40 years was brought to us by a volunteer. She wouldn't have ordinarily come to us. The volunteer said, she has cancer of the uterus, she is bleeding, she is in pain. She has lost all her medical records in the cancer center, so they scolded her and said, you can't come back here without the records. She was lying. Her story was not consistent. She was obviously telling us lies. And anyway, the cancer center wouldn't turn her back. They have most things electronically anyway. So our social worker sat beside her. Everybody in the healthcare, if you are not doing it, please note this. There's a lot of difference between standing and looking down at somebody and talking, sitting down and looking at the eye level. When I sit down even for a minute, the message goes out. You are the focus of attention. My time is yours. I know you are busy people. I'm not asking you to spend an hour every day. But the time that you spend, concentrate on the person and eye contact. So the social worker sat there and said, Chechi. Chechi means Akka. Chechi, there is something that you are hiding. And you are suffering. Please tell me. What is the problem? And it turned out that she had found herself to be pregnant. Single parent. 2 teenage daughters becoming pregnant. And you can imagine in our society, anyway a single woman is 100, especially if poor. And if she has pregnant, our moral hackles rise. It's only her responsibility. Men have nothing to do with it. The question arose in our unit, should we do anything for her? We are doing palliative care. How is it any business of ours? Pregnancy is not a life-threatening illness. That's how the WHO has defined palliative care, is for life-threatening illnesses. Pregnancy is not a life-threatening illness. It's not an illness anyway. Why should we be treating as? Those questions come out of definitions and guidelines which sometimes shackle us. Where do these definitions and guidelines come from? I have data that 93.5% of all literature on palliative care available on PubMed comes from 15% of global population, the Euro-American countries. 85% of the population, that we all, come out with only 6.5% of the publications. We are basing our definitions, guidelines, everything on what comes out of Euro-American countries, not recognizing the realities there. That happened to be the year when the Lancet Commission on Access to Palliative Care had brought out its report in 2017, which brought another angle into it. It is not offering as a definition, but it conveyed the clear message that palliative care is management of serious health-related suffering. Mitigation of serious health-related suffering, I correct myself. That is prevention and treatment of serious health-related suffering. Is this woman in serious health-related suffering? Of course. And it turned out that she actually had a life-threatening problem. The woman had bought poison to feed to the 2 children and then to kill herself. At dinner time, when she took it and looked at the children, she could not bring to herself to give it to them. So she kept it aside. I shudder at what could have happened. And, palliative care. Nothing that I learned in the textbooks would fit in with the needs here. We contacted a volunteer gynecologist, very busy clinician who would drive down to see our patient in the evening after her routine work. She came over. She said, "We'll keep it quiet. I'll take her to such and such a hospital and evacuate the uterus." The woman wouldn't agree. "Oh my God, I live in this town. If somebody sees me in the hospital, my children's lives are finished." The gynecologist actually drove 25 kilometers away, where our volunteer took her along with our social worker to another hospital far away and got the uterus evacuated. Would our management stop there? When she goes back home, what would she eat? She has not been working for about a whole month now. How would the children continue schooling? This is not only about that woman. In Kerala, officially, there is no starvation. Poverty is much less, I agree, but not when a disease strikes. I find that in the context of treatment, especially after filling a prescription from a hospital, the family goes hungry. And we continued to give her a food kit for the next 3 years till when she could stand on her own feet, monthly food kit. And we look after, she included those 2 children among the about 300 children whose education our organization supports. Is that healthcare? Without that, it's not healthcare. Health is physical, social and mental well-being, and palliative care by definition is for the patient and the family. But then, would a busy doctor be able to do that? And the answer is Dr. Matthew doesn't have to do this. We just open the door for the community to come in and do what it can. All that is taken care of completely by volunteers on the community. And the money, generally the public is most liberal with their wallet for children's education and for food, providing food to the starving. That's easily done. So, the problems that she has were physical, social, emotional and spiritual suffering. And by definition, by the Lancet Commission, by the definition by the Indian Council of Medical Research, the document that Dr. Saumya caused creation of, healthcare providers' duties define this. Remember, ICMR is a statutory body of the Government of India. India does not have a law defining the duty of the healthcare provider, so this is the closest to an official definition. Duty of the healthcare provider is to mitigate suffering. And the 14th century aphorism, to cure sometimes, relieve often, and to comfort always. Remember, see the next line. There exists no exception to this rule. There exists no exception to the rule that your duty as a psychiatrist, as a pharmacist, as a physical medicine person, as a medical social worker, as a psychologist, it is to mitigate suffering primarily. And there exists no exception to this rule. So I don't have to worry about other definitions. This is my duty, this is everybody's duty to do this. So we, for every patient, would give attention to all these 4 domains. Please remember that all the circles are encroaching onto the other. The problem in identifying these as different groups, he said we are creating silos. Okay, the patient is possibly in depression. Psychologist, to see the psychologist. Something else goes to the other specialist, and different people divide the patients. A writer by name Sindhu wrote this in the Hindu newspaper when her father was in an intensive care unit in Mumbai when he was terminally ill. She said he went on crying, "Save me, save me, save me." He wanted to go back home. Sindhu said, "I wanted to save him, but how could I? They have broken him down to segments which only they could put back. He is no longer that person. The heart belonging to the cardiologist, the kidney belonging to the nephrologist, they are all doing their management." One of the things that we have to remember is that though we try to identify problems by these definitions, we have to avoid these being done in silos without interaction between everybody. Every clinician has to look after has to address the social problems and emotional problems and spiritual problems along with the symptoms, along with treatment of disease, as much as he or she can. At least acknowledge them and find some support from somebody else. After all this long introduction, I repeat, according to the 2017 definition by the Lancet Commission report, palliative care is mitigation of serious health-related suffering. And when it was published, Dr. Richard Horton, who is the editor of the Lancet group of publications, came out with this editorial in which he said, medicine can never be the same again, because now this report is forcing our attention on serious health-related suffering, therefore making it imperative on us to do something about it. Earlier, when my old friends from Calicut and we were talking about different diseases, most of the time we associate palliative care with cancer. This is from a global atlas of palliative care created by the Worldwide Hospice and Palliative Care Alliance. And these are all the division between 20 diseases about what warrants palliative care. I apologize for the small print and the busy slide. I'm not asking your attention for everything, but please note, only about less than 29% of all palliative care needs are from cancer. Another large group comes with HIV, and then comes dementia. With the incidence being what it is, how many of palliative care units actually have a proportional number of people being treated with dementia? Isn't that a condition that causes horrible, horrible suffering? If God Almighty came to me and asked me, Rajagopal, you have to choose between these two. Here is cancer and here is dementia. What do you want? Vijayalakshmi says cancer. I would say the same thing. These are usually ignored, and all the central nervous system, cardiovascular system, all those diseases very often do not get the attention of palliative care units, even if a palliative care unit is available. These are things that we all need to think about, because when my time comes, I don't know whether you are a psychologist or a physiatrist or whatever, please attend to my suffering. I deserve to have my suffering treated. Please concentrate on that, not instead on stretching out my dying process on a machine. My medical professor with dementia, just 2 years back, dementia. He has been living with dementia for 8 years, not swallowing enough. He would swallow a little sip. You feed him, he would keep it in his throat for a while, and then slowly he'll take about 1 hour to have half a glass of soup. Unfortunately, among his 7 children, 6 were doctors. The one non-medical daughter said, "Leave him alone. Don't put all these tubes into him." But would our medical minds permit that? So we were trying to control his agitation, etc. till then, but at this stage, they decided to put the tube in. They put in a nasogastric tube to feed him, and he would naturally pull it out. What would you do? Hands and feet tied. He had been bedridden for more than 6 months. They had managed without a pressure sore, but at those 3 days, he got a pressure sore, giving him more pain, making him more agitated. Eventually came the inevitable ventilator. Dr. Darius, that's a great new disease of intensive careopathy. When you were a medical student, this did not happen. We still had ventilators, we had intensive care units. Intensive care units just 25 years back was for people who could be brought back to life by monitoring every organ minute to minute, intervening and causing recovery, when recovery was a possibility. Of course, not everybody recovered, but our intention was to bring the person back to reasonable quality of life. But today, it has become the norm. If you have any money in the pocket, you will be sentenced to rigorous imprisonment until death. I say it is rigorous imprisonment, it is rigorous torture. Rigorous torture because one person who went through this told me, anyway, that I have written that person's story in my book. He said, after the first day, when he saw the nurse coming from that corner, he would get very agitated and violent because he knew that suction catheter will go in. The respiratory tract is one of the most sensitive parts of your body, and a suction catheter going in, and gently be twisted as it is withdrawn, he felt like a red hot burning iron pushed into his insides and being taken away. The daughter said, "This was a man who gave a lot of love to others. He did not deserve to die this way." The elderly man with cancer, a fairly typical kind of person in the village, he would be spared of that kind of torture. It's still not comfortable for him, it's not good situation. But there are some issues that we medical people choose not to see. Loneliness is one of the worst diseases. There is no chapter in our textbooks about loneliness. It's horrible. How about people living with major disabilities? It is not there in palliative care textbook, except a line. They can also have, in Oxford textbook of palliative medicine, there is a sentence, they can also cause serious suffering. But they are not given attention because in the Western country where the textbook is written, if there is a spinal injury, they get rehabilitated, and after a month you see the person on an electric wheelchair doing his or her own shopping. What happens in our country? Slow, painful death with repeated urinary infections and infected pressure sores and septicemia after 30 years. Gender-based suffering is something we carefully ignore. Even in our center operates in a city, but we also operate in rural areas around, and we find that even in our population where 52% of the population are women, only about 42% of the patients are women. They are expendable. And substance use disorders. Substance use disorders, is that a disease? It is listed as a disease in the International Classification of Diseases. It is a disease. Causes intense suffering. We choose to look at them with pointing fingers and consider them criminals without realizing how much of suffering is there. So even today, even in good palliative care units, wherever they operate, we are unable to take care of these people because it's difficult to reach them. I mentioned that because for tomorrow's palliative care, tomorrow's healthcare, this is important. Please give attention to that sentence which calls 10-year-olds. In 2014, the World Health Assembly called upon all member countries, including India, to integrate palliative care into their health systems at all levels, meaning primary, secondary and tertiary levels of healthcare, across the continuum of care, meaning from the beginning and the suffering to the end. So, dear young friends, when my time comes, which cannot be too long away, I have only 10% chance of dying a sudden death. 90% of chance is that I will go through a prolonged illness before I go, like you. Sorry. That is true for everybody. And at that time, I hope my treating physician, general medicine, oncologist, whoever, will dare to look at my suffering also, not only at my tumor. And it is your duty. India is a signatory to this document. The Astana Declaration of 2018 called upon all of us to engage with the community to make this all a reality. They said, healthcare for all can only be healthcare with all. See, if somebody is to remain healthy, the health department alone cannot do it. You need agriculture, education, you need transport, everything. Irrigation, sanitation. All this is necessary to keep the local population healthy. And that cannot be achieved without engaging with the community, which is why in the Banyan or in our organization, we welcome the community. Is that possible to get volunteers to come in and help? I'll tell you the easy way to do it. Just open the door. Allow them in. Don't scare them away with the security guard. Open the healthcare door and welcome them in. And when they come in, please train them. They need basic training because they are coming into healthcare, including hand washing, including how not to communicate and how to communicate. Give them training and welcome them in. And that's how we can address all these problems together as much as possible. And remember, it is very comfortable for me to sit in my air-conditioned outpatient clinic. But the most needy will not get to me unless we reach them where they are. Hey, it's not me saying it. The global countries, including India, who signed this document, is saying healthcare for all can be only healthcare with all, and we have to reach them where they are when they need it. That means we have to get out into the warm climate, sweat a little bit, and reach them where they can't when they can't reach us. Not just the air-conditioned coach in a train, but we'll have to maybe get into a car and travel some distance, then get out of the car and walk uphill or downhill, and if there is no path there, break a new path. I cherish this photograph. This was taken in the beach in Trivandrum, Shangumukham Beach, on World Palliative Care Day. Around 40 people who were homebound, including people with cancer, with paraplegia, with a variety of diseases, and their families were brought by volunteers who college students from 2 engineering colleges came, about 160 of them, 4 to a home, bringing a patient, very often carrying them physically to the road, putting them in a vehicle, bringing them. What did it achieve? You see the girl in green and blue, red, who is a paraplegic who does not have normal sensation in her feet. She said, the waves touching my feet was the best experience that I have had in my whole life. You are applauding? Is that healthcare? Is that healthcare? What is health? Physical, social and mental well-being. That's the pinnacle of healthcare. And we professionals couldn't have got them there. And this is what we can achieve if we accept that healthcare is well-being, not only absence of diseases, and that it's achievable if we engage with the community. To summarize, we need palliative care. This is what we would like. People with major serious health-related suffering, whether it's cancer or dementia or whatever, would have major mental health issues. We palliative care physicians are not competent enough. We need help. We are thankful for the volunteer psychiatrists who drop in at least once a week. They help us. And this is something that will be totally necessary. And I hope we can work more and more closely with the Banyan to improve on this. More than 20% of people with cancer are found to have either clinical depression or clinical anxiety. And we are missing most of them. And the lives can be transformed if that treatment occurs. And for the families, in just a matter of 2 years, 2 young women had killed themselves, both the wives of young men with paraplegia. All our attention is on the paraplegia and the person, and the woman is not attended to. And that kind of thing, you can imagine if 2 people kill themselves, how many would be living wishing they had the strength to kill themselves. So these issues, not only with cancer, any chronic diseases, not only in the patient but in the family members. Again, in a span of within 3 years, we had 2 instances of children from families of patients. One was a cancer patient's child, and the other was a patient with paraplegia, traumatic paraplegia. A 15-year-old girl and a 16-year-old girl had become pregnant. Children receive very little attention, whether they are caregivers or just standing by at the home. The person gets seriously ill, all attention is on him. Children get neglected. The spouse is irritable, angry, and always snaps at the children, forgets to hug, and children grow up believing that dad is ill and mom doesn't love me anymore. Mom is dead and dad doesn't love me anymore. All sorts of things happen. Major emotional issues, but seeking attention and love somewhere. We had to sort that out also. I'm glad that one of them is now finally working in a Gulf country, yearning for the family and educating the younger children also. And these prisons have been created by oncology, thatology, thisology, so many ologies. And they are restricting us. We have to get person-centered care, irrespective of the disease, irrespective of the ology that is treating the patient. And psycho-oncology, finally, mental health given attention in cancer. Great advance, isn't it? We only psycho-oncology. Cancer is a high caste. Why is that attention not given to other diseases where people live through with that suffering for 30 or 40 years? Maybe a new thinking and attention to these problems will be necessary. And sometimes the solutions may be One Health, something that Dr. Saumya Swaminathan is working on, where we recognize that health is not only dependent on human beings, depend on the environment, animals, everything. And that's not only about animal-borne diseases. Very often, some children get amazingly better emotionally when they have a pet to be with. So, I'll wind up with these questions. What are we going to do about it? Can we integrate palliative care and mental health treatment? That is looking at all these issues the way the Banyan does across the country. And can we demonstrate attention to the family members who have who may have major mental health issues? And we should learn from the experience of the speciality of psycho-oncology. Learn from that, but not confine ourselves to cancer and apply it to healthcare as a whole. I'll stop there, and I hope I have left some time for any discussion. Thank you very much, Banyan, once more, and thank you everyone.
How do you see the unique propositions on developing an Indian model of palliative care, incorporating differences between the East and West?
Thank you. If we accept that our problems are not necessarily the problems faced by somebody in New York or in a European country, then we can dare to identify the problems, and the solution lies in engaging with the community. Community is engaged, the volunteers on the community is engaged, and if we dare to look at the psycho-socio-spiritual issues, we can address them, and we must address them, because we cannot keep on being restrained by definitions and guidelines from Euro-American countries.
Thank you. I'm combining a few questions, but what are the essential components of a multidisciplinary team in palliative care for community level interventions in mental health, including home visits?
May I put in volunteers from the community as the first important requirement? We cannot really address all domains of suffering if we do not engage them. Professionals cannot do it alone. So if we accept that, then on the professional front, well, there are some Indian standards for a palliative care unit laid down by the Indian Association of Palliative Care, and very clearly they, of course, name trained doctor and trained nurse. The other specialists not spelled out in that document. But we will have to get help wherever we can. Would a school teacher have anything to offer? Of course. So if we did not at one time, but we now have psychologists, but we rely largely on medical social workers. We also have physiotherapists and pharmacists who have training in palliative care. But if you ask me, if you are starting a palliative care unit, should all these be here? No, that's not possible, not feasible. A trained doctor is necessary to look at, and a trained nurse are necessary to look at what's at the surface, the pain and symptoms, without which the others cannot be identified. But ideally, all these physical medicine, people, physiotherapist, trained in palliative care, pharmacist, etc. will be necessary. But I believe medical social workers would have a great role, because they have a well-rounded training, including counseling skill. And social workers with us work as psychosocial workers.
Thank you. There's one question. Sometimes we get angry, frustrated when families are in denial for a long time, and that in turn hurts us. How do we manage?
Denial. Denial is not a very bad coping strategy. Now, Elizabeth Kubler-Ross has given these stages, reactions. Denial, no, this cannot be true. I cannot be having cancer. These doctors are trying to take money out of me, make money. I don't have cancer. Anger, bargaining. Bargaining means going to this temple, that church, this place, and going from Ayurveda, homeopathy, from this specialist to that specialist, and with bargaining with God. Okay, I will come to temple every day hereafter. Hereafter I will go to church every Sunday. He is not usually available for that bargaining that easily, but we try anyway. Depression, the black deep hole, and acceptance. Acceptance is the healthiest. Okay, sometimes ignorant, illiterate villagers, much stronger than we sophisticated society, arrive at that very easily. Sometimes, not always. Oh, well, after all I am 55, this is what one man told me. Well, after all I am 55, everybody has to die of something someday. But doctor, is there something some treatment to be done? If not, it's okay. That kind of people are there. But people in acceptance is the best. Second to that is denial. No, I am okay. The problem is the people in denial come to a stage when they can no longer deny. I will not try to break the denial unless that interferes with the treatment. Suppose the person has a curable illness and the denial will make it incurable, then I will work with him over some time and break the denial. If not, I will not intervene. Well, that's okay. Secondly, if I am in that position, please remember that this is my body, this is my right. You may be the great doctor, but I have more right over this than myself.
Thank you. There are a few other questions about caregiver support and mental health professionals, which are quite repetitive, and you've already addressed them. So I will just, we have 5 more minutes if any other members of the audience have questions that you didn't get to send in advance. So, yeah.
Thank you. I have too many questions. Just one. In my interactions with people doing any amount of care work, I've noticed that, and I come from an oppressor caste, in my family, in people I know, whenever there's any pain, discomfort, we access medical care, we access social support, we address it. But the more I interact with people across caste lines, look at their histories of accessing any care, there is a resignation to pain. There are these narratives I keep coming across in the religious casteist literature about how some bodies are condemned to a life of pain. Hello? Yeah. So they're condemned to a life of pain. And like a lot of the justification is religious, but a lot of the contexts which perpetuate it are social and institutional. So I just wanted to hear your experience on the field with this.
Faith can be a strength, no doubt. But faith and belief can also cause a lot of suffering. Very often, see, any religion, if you deep into it, you can find the best, most comforting things. You can also find enough to destroy people. So sometimes, unfortunately, the negative happens. And I can remember any number of people who were troubled by the religious gurus who said, the priest of one church said, this is given to God by God so that you can suffer in this life and go straight to heaven. You shouldn't. It is against God's will to treat the pain. That happens. It is the person's choice, of course, and unfortunately sometimes it is not the person's choice. The family tries to do what they can. The person has lost the power, he is weak, the family still has the power. They are very they have decided to get him a visa to heaven, and they insist on the pain. These things happen, and sometimes we are helpless. What we would try to do when a religious elder takes that kind of attitude is to get a second opinion. Sometimes it works. But the solution for the future is, okay, in Western countries where most people are of Christian faith, they have chaplains. Chaplains who are taught counseling skills and who can treat people of any faith. But there they understand diseases, maybe we should have them. But this belief that willpower can overcome pain, that's rubbish. I have treated people of different religions. I have never seen one that with a severe painful condition has overcome the pain by their faith and strength. At some point they break down. You heard the story of Ramana Maharshi. He had conquered pain when, this was just a century and a half back, he was operated in Tamil Nadu by Dr Saumya for appendicitis, and he had refused anesthesia. And during the surgery, Saumya asked, "Don't you have pain?" Ramana Maharshi said, "Odambukku Enakkenna." Dissociation between the mind and the body, great. But Ramana Maharshi had cancer eventually, and after the third recurrence, when it could not be operated, at that night, in the nights, he could be heard groaning and screaming and crying. So the power to dissociate the mind, or power for spiritual pain to overcome physical pain, I believe is bounded by some level beyond which it gets not operative. But maybe I have not seen enough. Maybe there are heights of religious beliefs which may achieve that. But among the tens of thousands of people that I have seen, I have not seen that happening. Have I answered your question? Not quite.
Yeah.
Clarify your question, please.
I think it's not as much about people saying that I will conquer my pain because of my religious beliefs. It's as much about people are not given access, or they don't believe they have the right to access it or take a break. Like people who are daily wage laborers who have to go back, someone who can't afford that 25,000 rupee intervention, but they're having to go back to work day in and day out. They're not able to take a break from life to care for themselves. And they're being told they're not allowed to, that it's a punishment that they must live with. So it's a mix of both, but to shift from the punishment to belief in wanting to care for the self, to also being able to provide that access, given that it's daily wage, or the conditions are too precarious.
The one possible solution I can think of is people from the community being engaged, people around them. I am a stranger, and anyway they are scared of me because I have too many degrees. People of that community, if engaged, may find the answer and speak in their language. I have seen that happen in northern Karnataka with Samraksha, the organization run by the great human being Sangamitra Iyengar and colleagues. I have seen the social workers who are living with HIV going into the community, talking to the villagers, and in the second or third visit they get the person accepted back into the community. And speaking their language and engaging with the community is the one answer that I can think of. But you have asked me a difficult question. I am not sure that I have the complete answer.
Thank you. Anybody else? Yes.
Thank you, sir, for this thought-provoking talk. I'm a doctor who deals with cancer patients every day. So whenever a patient comes, especially patients who are in the curative phase, and they come and we tell them about the surgery and the treatment involved, the cost of chemotherapy, they do express their concerns with the financial implications. They say there is nobody to support them, nobody to look after their children, and they also express all these issues. But I'm not able to give them a solution. They will be somewhere from outside Chennai. So what do I tell them? How can I help them?
First of all, my respect for your concern. It's easy for you to say, you get this treatment, if you can't afford, how can I do? But you are concerned. Thank you for that humanity in you. But there are two aspects. As a doctor treating cancer, you can think twice about the financial situation and what is affordable. Always there will be more and more expensive new modalities of treatment coming in. And if you feel duty bound to offer all of them, you may be only causing suffering. Maybe we can gently guide them. Okay, there may be more expensive treatments, but if this is the situation, this will be the best path to follow. But doctor, I thought in Tamil Nadu, cancer treatment is free for people below poverty line. Yes, but still, let us not be fooled by this. There are always many unseen elements of expenses. I am in Trivandrum, which is practically very close to the Tamil Nadu border. Therefore, many people come to the regional cancer center. And once they are treated there, they don't get the consideration. They are from outside the state. They have to pay. So they come back here. And here very often they are told, oh, you went there for treatment, go back there. And these problems happen, which we will have to sort out by engaging with people like Dr. Daras. But I believe we have a duty to customize the treatment, facing the reality on the ground, giving them the best option that's affordable. And of course, the community coming in can do a lot. I have seen so many organizations raising funds to facilitate treatment, and we can only be the link between them. I wish I had a better answer to give you.
Yes, sir. Thank you.
Sir, thank you so much for this session.
Please continue. You have started anyway.
Yeah. So I wanted to ask about where does the question of like euthanasia come in palliative care, and is it something that needs more attention in India particularly?
The inevitable question of euthanasia comes in. The easy answer is, it is illegal in our country. Legally, euthanasia is murder. Not possible. End of story. But if you ask me about the ethical aspect of it, I would say you and I have no authority, no moral right to discuss it. Listen, if I am the patient and I am coming to you in agonizing pain, kill me, I can't stand this pain anymore. What should you do? Should you find out why I am saying that and treat my pain? Or should you say, come lie down, let me kill you? Remember, all those countries which have legalized euthanasia, starting with Netherlands and now latest perhaps Canada and Switzerland, where now there is euthanasia tourism. And all these countries have made palliative care available. They treat the suffering and only then they consider euthanasia. And here, where we are denying palliative care to more than 96% of people, how can we even think about it? That will be a sad moral story if we are not willing to provide even inexpensive palliative care, but we think seriously about euthanasia. Sir.
I think that will be like putting the cart before the horse. So I want to thank you for opening out the sphere of integrating palliative care, extending it, and integrating mental health into it. So I just want to know if you have any kind of numbers, like if you want to have centers, if you want to have a palliative network integrated with mental health care and all that, what would be that? Like we have PHCs or rural health centers which serve so many people. Is there any kind of number like that? So if you want to think of such a network for palliative care.
Thank you, sir. What do you do, may I ask? What's your profession? I mean, I know that a lay community member can be the most valuable person for this. Are you a professional or a human being?
I don't know. I don't know whether I'm a professional or a human being. So basically, I'm certified to be a psychiatrist.
The numbers. The number of people with serious health-related suffering in India is estimated to be about 10 million or 1 crore. From 20 days alone, we have data to show that about 7 million people are in serious health-related suffering at any point of time. Are they getting access to palliative care? We can only have indirect data. That's that is the basis for our estimate that less than 4% of people have access to pain relief, even basic pain relief. So those are the numbers. Now, very interesting question. We all need to think about it. How will we provide palliative care to all these? How many palliative care centers will be necessary? My answer is, for the majority of them, we don't need palliative care centers. The answer is what the World Health Assembly gave in 2014. Integrate palliative care into all health care. Like it happens in European countries, every medical student, every nursing student, every pharmacy student learns the fundamentals of palliative care. And if to the oncologist or the general practitioner, I come with severe pain, they are not only ordering the CT scan, as happens in our country much too often, they would also be treating my pain. And only if that person is unable to give me satisfactory pain relief, I would be sent to a palliative care unit. So the bulk of the palliative care delivery would be by integration of palliative care with all health care. And more than we think is already happening. 2017 National Health Policy includes palliative care as part of primary care. Already national level trainers and state level trainers have been trained. Let us hope that it will be rolled out so that everybody will know the basics of pain relief, which today is not taught. And from 2019, MBBS curriculum includes palliative care. From 2021, BSc nursing curriculum includes palliative care. So that would be the bulk of the palliative care delivery. Once they have studied it, if oral morphine is necessary, every doctor will prescribe it. Thank you for that. I mean, apart from anesthesia, this is the other inevitable question that comes into place. So, as it happens, there's a lot of interest in cannabis, and we know that culturally, especially in some parts of India, That has become part of routine life, part of every celebration. And it has uses. I won't challenge that. But unfortunately, I believe there is too much of interest in cannabis and too little interest in plain, simple opioids. Take cancer pain. 2/3 of all cancer pains will be relieved by opioid medication. Another 20% can be relieved by opioid medication in combination with other measures. So most cancer pain can be treated by opioids. Well, the numbers will be difficult to quantitate with other diseases, but this holds true for other diseases also. Now, cannabis, by evidence, is useful in some kinds of pains, particularly nerve pains, neuropathic pains, where pain occurs by infiltration of a tumor or infection into a nerve. For them, cannabis has an advantage. Therefore, its value in cancer pain management may be limited to less than 10% of all. Now, you have to balance that against the good. The thrust for legalization of cannabis is, unfortunately, I believe, also partly by, well, here's an easy solution available in India. Let's do it. Where is the easy solution? Unfortunately, cannabinoid oil is become very, very expensive. And it's not affordable. It may be useful because it has other advantages also, including giving the sense of well-being. But if you ask me, I would concentrate first on what will give easy relief for the majority, rather than experiment on something very expensive which will be useful for only a minority. Tomorrow, when generally opioid medicines like morphine are available for most people, then I believe we should be thinking about cannabis more. But a lot of experiments are happening all over the world, and maybe tomorrow we would have a better answer. Thank you.
Last question. I'm Vijaya Bhaskaran, sign language interpreter for 50 years, sir. I'm always thinking of hearing impaired only.
Thinking of?
Hearing impaired persons. Person with ear, not able to hear. So I'm concentrating on them. Because of them, I'm asking this question. When the patients, both parents are deaf and dumb, they visited the hospital in Cancer Institute. What the doctor says, they were not able to understand. Even from the basic they are explaining, they don't have the sign language interpretation in the screen. If they have that, they can understand what is going on. If it is Tamil or any other language, that is okay. So if it is sign language is there, they can understand. So this is the problem we are facing. So they were not able to understand even a single word because of this language problem and all. So then they came to my house and explained to me. Then I talked to the doctor. Luckily they're having that number, everything. So I talked to them and she said it's not easy to explain in the phone. You come to my organization or you come there, I will explain to you. So both went there and explained each and everything. So after hearing everything, they got upset. They were not able to tell anything. So they mentally got stretched, everything. They were not able to even face the same thing what we are discussing today, financial problem, this problem, that problem, getting the medicine also, everything is there. So she explained everything. So I request everyone here, they're going to start the, whatever the level you are, please have sign language, whatever the you are displaying here in sign language. So that they can also, inclusion will be there, they can also understand what is going on. Because cognizant person is here, I'm requesting you, sir, you can concentrate on this and you can expose this also to everybody. I'm very thankful to, sir, I'm very good, thank you, sir.
Thank you so much.
Thank you.
And thanks everybody. Thank you so much, Dr. Rajagopal. Everybody in the groups have just been raving about what you've had to say. I'll just request Dr. Kishore, our director, to speak, to just say a few words of thanks and also to gift some small mementos to our chief guest and our speaker.
Good evening, ladies and gentlemen. I think you will agree with me that we had this opportunity and privilege to listen to distress mitigation strategies for people in the country, and this was presented in such a smooth, sensitive manner by Dr. Rajagopalan. As we all know, that disease that affects an individual has a reaction to it. The family experiences distress. The larger society also experiences tremendous distress, which includes economics, social isolation, discrimination, and so many other things like that, which requires attention at the level of family, at the level of the larger society. As Dr. Rajagopalan has mentioned, while the need for palliative care can be so high, do we have the resources to keep in place a system? He described so beautifully the levels and limits of care that may be necessary in palliation. Much of this work can be done at the level of the community, at the level of the household, and only a small proportion of them will require higher level of care. This presentation was so beautifully presented to us, which was an eye-opener to understand how medicine can become humane, user-centric, at the same time be conservative in their approach to focus on very cost-effective methods of reducing distress. I am deeply indebted to you, sir, on behalf of the organization. I thank you very much for this wonderful narration on palliation, and also the need to become human in our approach to provide care. I see a lot of parallels that can be drawn from palliative medicine to the concept of home care for people with severe mental illness. Close to 30% of people continue to live with symptoms despite what we do. This is true across the world as much as it is true in our country. Often these people experience so much distress, the system conveniently closes its eyes towards them, and the end point of all this is an unmeasured, untold misery in the form of hopelessness. Surely we will explore the possibilities of making this happen. Many states in our country has learned from it, implemented it in their own way, and one state is the state of Tamil Nadu, which is Makkalai Thedi Maruthuvam. So it focuses on care at the doorstep. I am sure this will go a long way to integrate medicine so that many conditions can be addressed. I thank you for your patience, and I am sure you will go back home with a lot of experience, having listened to Dr. Rajagopalan, to take the message that medicine can be practiced at home if we apply common sense, if we think in humane ways of mitigating distress. I thank once again all of you for this patience that you have demonstrated, and also reflecting upon Mr. Keshav Desiraju's legacy of concern, simplicity, so that the larger society benefits from our actions.
Thank you, Dr. Kishore. Please stay back. So thank you, everybody. I just request Dr. Kishore, Dr. Rajagopal, Reena Elizabeth, and Usha Raman to just come on stage for a photo, and for us to just give Dr. Rajagopal a small token of thanks from the Banyan. Please come, Dr. Kishore. That's for Dr. Rajagopal. Yeah. Thank you all so much. Before you go, just a few quick housekeeping announcements. I will just let everybody get back to where they're sitting. For those who have not registered and who would like to be part of future events like this, we have a registration form outside. Please fill that out with your details. There's also lime juice and samosas outside for you to help yourself. And most importantly, Dr. Rajagopal's book, Walking with the Weary, it's just amazing and so moving, and has gotten raving reviews from across the world. So please pick that up as well. Thank you very much for joining us, and have a good evening.